pleasure and honor to have Professor Bjorn BACHMANN all the way from Germany. Thank you for coming for us, and he will be talking about endo art. I guess that's the next thing we want to hear from you.
Yeah, so thank you for inviting me. It's a real pleasure to be here. It's a great congress. And yeah, so we heard a lot about DMEC, and my topic is about endo art. Still, I want to start with DMEC. So I want to start because DMEC is not only beneficial in terms of better quality after transplantation, in terms of visual acuity for the patient, but also we see much less graft rejections after DMEC compared to all other transplantation techniques we had before the introduction of DMEC. So this is our cohort from Cologne, where we showed that we have a graft rejection rate of 2.3% after 4 years, and the average duration until rejection took place in our patient group was 9.9 months. So we barely see Coda-Dov's lines, as you can see here in this example after DMEC. This is very, very rare, and if you see this, this is typically at the periphery of the graft. So can you see my mouse here? No.
Mouse for the
here.
speakers?
I think I made it. Okay, great. So you can see the Coda line here, typically at the periphery of the graft. Usually, if you see rejections, you will see deposits all over the graft or at certain areas of the graft, but not as a line typically. Again, here, this is an example of a Coda-Dov's line, and here it became worse first, and then after treatment, the cornea cleared up again. So this is a good message about rejections in DMEC. Many of those cases, if you treat them aggressively with steroids, you will convert them into normal dehydrated corneas again. So, but as you can see here in this example, this is not a regular Fuchs patient. So this is a patient who had different surgeries before with scar formation here, the neck here, and so on. So these are patients which are at higher risk for developing a graft rejection after DMEC. And there's two papers which describe the influence of the blood-aqueous barrier by measuring the flare before and after transplantation. And this is one paper from my colleague from a different university hospital in Germany, Lami Baidoun. She published in 2018 her DMEC cases, where she showed that higher postoperative flare after DMEC in the early phase was also associated with graft rejections later on. And this was also something which was published in a PK group some years before already. So they also found that higher postoperative flare was associated with later rejection. So this comes to the thesis that the disruption of the blood-aqueous barrier promotes graft rejection after PK and also after DMEC. So if you look at our cohort of patients from our own university hospital where we perform DMEC, the majority of our patients are Fuchs patients. Then we have around 5% of our patients with Fuchs pseudophakic bullous keratopathy. And then we have a much smaller group of other patients. Less frequent indications are, so let's say, among the group with little patients or with few patients, we have this larger group of patients with glaucoma drainage device or other glaucoma surgeries. And most of those indications, they come with a disruption of the blood-aqueous barrier, and we think that these patients are at a higher risk of having a graft failure and graft rejection after DMEC surgery. And we analyzed our cohort of glaucoma patients, divided them into a group with trabeculectomy and glaucoma drainage device, and one can see that the graft failure rate is very high. So you can find within 2 years around 50% of all those patients with glaucoma drainage device a graft failure after DMEC. And after trabeculectomy, it's a bit better, but still you have a very high rate of graft rejection and graft failures in this group of glaucoma patients. So and then we had the possibility in Europe 2 years ago almost to use a new device which is called Endo art. It's what we call a endothelial keratoprothesis, which we started to use in those high-risk patients. The principle is completely different, of course, from the principle you know from DMEC. So there's no active process in pumping out the fluid from the stroma. It passively seals the posterior surface because it's attached to the posterior surface of the cornea, as it's also performed in DMEC with the graft. But it prevents the inflow of fluid into the corneal stroma. It's made of hydrophilic acrylic polymer, so you know this material from IOLs. and it has been CE certified some years ago in Europe, but became available at the market around 2 years ago. The diameter is a bit less than the diameter we typically use for grafts. So in DMAX we use an 8 millimeter diameter. This is only 6.5 millimeter. The thickness is much thicker than a DMAC graft. It's 50 micrometers compared to 15 around in DMAC grafts. And the surgical procedure itself is very easy. As you can see here, you remove the diseased desmoid membrane, and here are certainly no living endothelial cells available in this case. At higher magnification, you will see here a marking down here. It's an F mark, which helps you to keep the orientation during implantation and after implantation. And then it's simply pushing the device with a spatula into the anterior chamber. You can do this under irrigation, and then it unfolds automatically, almost automatically. And even if you then pull it or push it against the posterior surface by an air bubble, and it's not completely well centered, it's easily moved by a hook, till example, to the center. And then at least one fixation suture should be applied, as seen here. And we also close all entrance wounds to really have the wounds tight and to avoid the outflow of gas after the surgery. And so as you can see here, this fixation suture, this is needed because the attachment of the device is much worse than the attachment we know from grafts, from DMAC or also from DSAC grafts. This is a clinical example of a patient who had a perforating trauma some decades ago. Then he had cataract surgery, he developed an implantation cyst, and this was excised. This was here in the upper outer quadrant. And then he had a PK, and he also had the implantation of an artificial iris. So this is what we really consider to be a patient at higher risk of graft rejection even after DMAC. So we discussed with the patient the possibility to perform the implantation of the EndoArt device, and as you can see here, once it's attached to the posterior surface, then there is a good dehydration of the cornea, and it gets even low till 433 micrometers in this endothelial decompensation after PK. So we analyzed the cohort, which we also published in 2024, of 44 EndoArt surgeries and 38 glaucoma, of which 38 glaucoma patients were glaucoma patients. 17 of those patients had a glaucoma drainage device. 80 patients had other types of glaucoma surgeries before. 22 patients had previous DMAC surgeries. Many of these patients don't even had just one surgery or two DMACs. Some also had 3 or even 4 DMAC surgeries. And 6 patients had a previous PK. Here another example of a patient with a glaucoma drainage device. And there's a good dehydration if it is attached. This is an improvement in visual acuity, and these are all patients with low expectations in visual acuity, though there is quite an improvement. This is logMAR visual acuity, but the level of these patients is of course very low. But as you can see here, the dehydration of the cornea, or the stabilization of the edema of the cornea, works quite well on average. So the mean preoperative central corneal thickness was almost 800 micrometer, and the average thickness 3 to 4 months after surgery was around 500 micrometers. So the main complication is graft detachment, and the main additional surgery which is needed, of course, is then rebubblings. And we compared, we divided the whole cohort into 2 groups. One group was a group with iris lens diaphragm defects, and the other had an intact iris lens diaphragm. And as shown here, one can see that we needed up to 5, at that time of analysis, 5 rebubblings in the group with iris lens diaphragm, because there's a very rapid displacement in many of those patients of the air bubble from the anterior chamber to the vitreous cavity. And in the group 2, without any defect in the iris lens diaphragm, we also needed rebubblings quite often, but the maximum of rebubblings was only 3 times. So we also add additional holding sutures if we need additional rebubblings. So if a patient receives 2 or 3 or 4 rebubblings, we place at the time of rebubblings also additional holding sutures. And we had here a patient which also needed 6 holding sutures at the end. And here in the group 2, we only needed 3 holding sutures. We also wanted to know the influence of the glaucoma drainage device on the rebubbling rate. And if we divided our cohorts into the patients with glaucoma drainage device and those patients without glaucoma drainage device, we found around 50% of the patients with glaucoma drainage device needed a rebubbling, and you had more patients in the no glaucoma drainage device group, which also needed a rebubbling. So I want to finish with a complex case again. This is a patient, again, after penetrating eye injury. She had a corneal scar, aneurysm, aphakia. She had developed secondary glaucoma the years after the trauma. Then she had several cyclophotocoagulations, and she showed up in our department in 2018 with an endothelial decompensation. We implanted first an iris, artificial iris diaphragm, sclerofixated IOL. Then we performed DMEC after the first healing of this first surgery. There she needed 3 rebubblings. The cornea looked very nice. She had a good vision again. Then after 2 years, she had graft failure. We performed additional DMEC. She needed 3 rebubblings at that time. Then this was good for 3 years. Then again, decompensation, re-DMEC. But there she had a primary graft failure. We failed to have the graft attached despite the rebubblings. There was complete detachment of the graft. And then we decided to perform an endoart. After endoart, we needed 7 rebubblings at the end, fixation sutures, many fixation sutures to have the graft attached. You can see here this complex case. You can see the endoart here. Still here, the cornea is a bit thicker. We placed additional sutures, rebubblings, and then the cornea gradually, the thickness decreased over time. And but then we had the graft almost completely attached, but then she developed a fibrosis over the device, as you can see here, this thin reflection line, and this became thicker over time. And at that time, the cornea was quite thin, at least the part of the cornea which was anteriorly to the device. And then very recently, just removed the fibrosis, which is possible. Then the cornea in the center became clearer again. And yeah, so the cornea was, after removal of the fibrosis, still thinner, a bit thicker than it was before removing the fibrosis, but still the endoart is in place. So we are still looking at the patient, and we will see how the story will end. So in summary, disruption of blood aqueous barrier is associated with higher graft failure rates after DMEC. Very high graft failure rates come in patients with glaucoma drainage device. The novel endothelial keratoprosthesis endoart could become a game changer for high-risk eyes. There's no risk of graft rejection, of course, there are no cells. It's a very simple implantation technique. It's suitable for complex changes of the anterior segment with anterior synechia, artificial iris, or aphakia. There is a decrease in the corneal thickness and high-risk endothelial decompensation, but the question was, how far can we go? We can go quite far. We can adapt this in almost all of our patients, but you need to talk to the patient before that there will be quite a high number of additional surgeries after the main surgery. So you need the rebubblings, you need additional suturing, but this is something which takes quite time in these special group of patients. So thank you for your attention.
Bjorn, that's great. Sunita, you had a question, is that right? Or
Yeah, we have time for questions. So one question, Dr. Bachmann, very nice presentation. And so what do you feel would be, do you think like Fuchs specifically, would that be an indication for this EndoR device? Because I think we have Professor Lionel Raj also, and we were a part of the phase 2 trial, both of us. And what we have seen, eventually what happens is that in the beginning it does well, but from the periphery you have some bit of epithelial hypertrophy, which happens because there's excess of fluid in the periphery. So would you think like a case like a Fuchs, where the peripheral endothelium is healthy, so you still maintain the balance, osmotic balance in the periphery, would that work better in these eyes compared to other indications as well? So what are your thoughts on that?
Yes, so since this device is more or less new also at our place, so we haven't dared yet to use this device in regular Fuchs patients because the diameter, as you said, is smaller, and usually you see this edema in the periphery or adjacent to the device, and it could work, but we haven't done yet. We don't have such a shortage of donor tissue, and the results of the DMEC are very, very good. And our experience with this group of low vision expectation patients is also that if they have the experience with DMAC before, most of them will tell us the vision was a bit better after DMAC than it was after EndoArt. However, they also acknowledge that they have stable situations once the device is working, and they are happy that they have something which might last for a much longer time, hopefully, than it would last after DMAC. So this is a true benefit, at least in this group of patients. So I cannot really tell how this works out in patients after Fuchs, but we have here an expert on this.
Thank you for the wonderful session and a nice presentation. I do agree what you said, and that is the very reason we always say when we go for endothelial keratoprosthesis, try to preserve as much as endothelium in the periphery. So the descemetor axis, try to have a maximum of 7 millimeters and not beyond. Otherwise, the peripheral cornea, this endothelial keratoprosthesis is just a barrier. It doesn't have an endothelial pump mechanism. So the peripheral corneal endothelium is very much essential. We shouldn't be sacrificing too much. Otherwise, we'll start having bullae in the periphery. Most often, we might have to do some punctures until it gets scarred or hypertrophied. So that is one important thing.
You would agree that this will apply to Fuchs, but not as much in the PBK anyways, we would have
Understand. I understand. So as much as possible.
Yeah.
So it's meaningful to have only 7 millimeters of descemetor rectus in the center. The device is only 6.5.
Yeah. Even Dr. Offer, what he conveyed is that some of the best outcomes probably would be failed DMAC, because you had some series of failed DMAC and failed PK, because where the periphery still maintains the corneal deturgescence. So in the failed PK, I've done one. I think that was one of the best results I've got in EndoArt in the long term.
And can I ask about visual acuity compared to DMAC? Do you have a feel for that?
So as I said, some of the patients, they have the best feelings because they have the experience of the DMAX before and then the EndoArt. And some say their feeling is that the visual outcome is a bit worse than it was after DMAC. But the EndoArt is in a row of, let's say, 3 or 4 DMAX sometimes. So also the stroma becomes a bit worse with each procedure you perform, though they have swelling for a couple of months again before doing the procedure, the next DMAC, and then again edematous cornea for quite a while. So this makes also something to the stroma. That's my experience. So the stroma looks different if you have a short period of edema or whether you have a long period of edema. So it's really hard to have a good feeling the difference between EndoArt and DMAC on visual acuity in these patients.
Sumit, I just want to ask you, since you have also used the device, was your indication a little different? Because in India, we do have a lot of end-stage eyes, wherein multiple PKs have been done.
Yeah, so the study which was phase 2, and Dr. Lionel Raj was also a part of that, and that was a 1-year outcome. So that 1-year outcome is pretty good. But in the long term, like when we are following up those cases, we have this problem of periphery being, having that, and most of the indications in the phase 2 trial were all bad in the sense like they were not like very clean indications. They did have a good potential. The initial results are good, and that is why I feel, and I'm sure Professor also agrees, that it is where you have situations where the periphery of the, cornea is little healthier, is at least has some endothelial cells, might do better, because failed PK and failed DMAC, where you have periphery, sort of better. That kind of cases may have a little better indication. So I think we need some more data on that. But certainly the device may have good application in many of the conditions. And as what you pointed out, in failed, in cases where you have glaucoma drainage devices where donor tissue is a limitation, and then it's not just the graft rejection, but the non-immunogenic causes of failure is also pretty much high because of the reasons you pointed out.
If I can just add very quick regarding the visual acuity, it was in our series, the baseline was 9 ETDRS characters, which by month 32 now is 44 plus characters. Quite reasonable for certain indications, yes.
It's not commercially available here. It has DCJ approval, but it's not commercially available.